right, good afternoon. I can't compete with Sarah's sit to rise test. And I'm going to take my homework home and do it in the privacy of my home before the Super Bowl, maybe. All right, so today, I want to just talk to you guys about the management of metastatic hormone receptor positive breast cancer. It has certainly evolved over the last 10 years. And, I think, the really great things for our patients, especially in these solid tumors where we talk about GI malignancies, lung cancer, and breast, is these targeted therapies have really revolutionized how long patients live. These are my disclosures. So I just wanted to start off with my key take-home points here. First, many of us know that CDK4/6 inhibitors remain the first-line standard of care in endocrine-sensitive hormone receptor-positive breast cancer. There potentially is some role for CDK4 use after CDK4/6 inhibitor progression, and we'll talk about those for those specific cases. We certainly also know that we have more targeted therapy available in the second-line setting, or this kind of post-progression adjuvant setting that we're seeing now. And it's very important to do the molecular testing, and we heard a lot about that during our lunchtime hour. And then certainly we're going to examine the role of ADCs in single-agent chemotherapy in those tumors that have become endocrine resistant or patients who are experiencing visceral crisis. So again, 70% of the patients that walk through our clinics will be diagnosed with a hormone receptor positive HER2 negative breast cancer. And we know that the 5-year overall relative survival rate is about 34% in hormone receptor positive metastatic breast cancers. And as you guys can see here, since 2014, 2015, it's really evolutionized the dynamics of what we have available for our patients from the CDK4/6 inhibitors, the targeting the PI3 kinase pathway, mTOR pathway, and multiple ways to target the estrogen and progesterone blockade pathways as well. We are all now very familiar and very comfortable prescribing CDK4/6 inhibitors to our patients, especially in those endocrine-sensitive or naive therapy patients, both in the postmenopausal setting as well as the premenopausal setting here. We also are, again, very familiar with utilizing those agents in endocrine-resistant therapy without any prior chemotherapy, and studies like Monarch 2 and Paloma 3, and certainly there is their availability of endocrine-resistant therapy with prior chemotherapy with single-agent CDK4/6 inhibitor abemaciclib that we saw in Monarch 1. So, typically when we see patients that have endocrine-sensitive disease or endocrine-naive disease, and those de novo metastatic patients, we now know that those patients, no matter the CDK4/6 inhibitor that you're selecting these days, on average will have about a 2-year progression-free survival or even longer on those therapies. And they tend to be pretty well tolerated. So let's talk about CDK4/6 inhibitor, post-CDK4/6 inhibitor. Is there any utility for that? So first I want to point out the post-Monarch study that evaluated these patients who had hormone receptor positive HER2 negative advanced breast cancer in men and women in the pre- and postmenopausal setting. These patients also were noted to have disease progression on adjuvant therapy or disease progression on prior CDK4/6 inhibitor as an AI therapy as their initial therapy. Patients were randomized 1-to-1 setting to get the doublet therapy versus fulvestrant alone with a PFS endpoint. And we can see here that over 60% of the patients had visceral disease, over 60% of the patients had CDK4/6 inhibitor either in the adjuvant or metastatic setting. Additionally, over 70% of the patients had CDK4/6 inhibitor for over 12 months. And I want to bring your attention to this Kaplan-Meier curve, which shows progression-free survival 6 months versus 5.3 months, which was statistically significant, but small clinical change when you're a physician looking at this in the clinic. But we did, the investigators did break this out into patients who had prior use of CDK4/6 inhibitors, who were on their initial CDK4/6 inhibitor greater than 12 months. And you can see on that Kaplan-Meier curve to your right there that the doublet therapy outperformed in those patients compared to fulvestrant alone. Additionally, those patients on the left side of Kaplan-Meier curve that had no visceral disease seemed to also gain the most benefit as well. And no matter the mutation carrier status, whether ESR1 mutated or PIK3CA, AKT, or PTEN mutated, there seemed to be some benefit in the doublet therapy as well. We're going to move along to the MAINTAIN study here, also looking at CDK4/6 inhibitor after CDK4/6 inhibitor use. And most of these patients, 87% of those patients had palbociclib and exposure, and 60% of those patients had visceral disease. Additionally, over 83% of the patients, when they were asked to switch endocrine therapies, the physician switched them over to fulvestrant, 83% versus 17% in exemestane. And I think it's interesting, too, that, again, this is one of those things that are useful in certain circumstances, that did seem to be a delta of 2.5 months difference in the ribociclib plus endocrine therapy arm versus a standard of care endocrine therapy. Additionally, if the patients did not carry a ESR1 mutation, so they were rather ESR1 wild type, they seem to gain the most benefit. So again, this CDK4/6 inhibitor after CDK4/6 inhibitor may be useful in certain circumstances. So what about those oral SERDs? We, again, had a long discussion during lunchtime about the EMERALD study, so I won't spend much time on this, but as you guys know that patients on the EMERALD study were hormone receptor positive, metastatic breast cancers, and had previously progressed on 1 to 2 lines of endocrine therapy, and one of those endocrine therapy backbones must have included a CDK4/6 inhibitor. The investigators did stratify the patients according to their ESR1 mutation, and patients were randomized in a 1-to-1 fashion to elacestrant versus endocrine therapy choice of the investigator. And again, those patients who gained the most benefit in progression-free survival were those who had an ESR1 mutation, as well as those who were on prior CDK4/6 inhibitors for greater than 12 months. So you can see there in the Kaplan-Meier curves to the middle and the 18 months on the far right. And there was also a benefit in overall survival as well, particularly in the ESR1 mutated patients. We'll skip over to EMBER-3, which was a very exciting presentation during San Antonio, looking at that same patient population. And the SERD that was utilized in this study was imlunestrant at 400 milligrams daily compared to standard of care fulvestrant or AI. The investigators also added a third arm later on the study, combining imlunestrant with abemaciclib. And you can see here that over 40% of the patients did carry ESR1 mutations or a mutation in the PIK3CA mutation pathway. Additionally, about 60% of patients had prior CDK4/6 inhibitors, and most of those patients had prior palbociclib exposure, so 61% or so versus ribociclib at 30% there. And if you look at the primary endpoint of progression-free survival in the oral SERD imlunestrant versus standard of care in patients who had an ESR1 mutation, the PFS was 5.5 versus 3.8 months. Additionally, if you looked at the doublet combination of imlunestrant plus abemaciclib versus the oral SERD there, the doublet in the red, you can see that patients who had ESR1 mutations, as well as those who were wild type, gained benefit in the doublet arm, which was, I think, something surprising that we noted as investigators. The overall survival data is still not quite mature, but you can see that maybe there's a trend for benefit with the doublet, but we'll be waiting for additional information on months to come. So let's target the PI3 kinase pathway a little further and look at what we have available as part of our standard of care. So we know that 50% of all breast cancers will have a hypermutation in that PI3 kinase pathway. Most of them will be the PIK3CA mutations, at about 40% expressed, and then AKT1 and PTEN are about 5% activating mutations or alterations. So in SOLAR-1, alpelisib was the first PI3 kinase inhibitor that we have available as standard of care, and patients were randomized to alpelisib versus fulvestrant after progression on standard endocrine therapy in the advanced setting. And what we saw there is that the doublet combination had 11 versus 5.7 months progression-free survival over fulvestrant alone. The critique in this was that most patients, of course, this was before the wide use of CDK4/6 inhibitors, so they did follow this up with the BILE study that showed improvement in the combination. Recently, during San Antonio Breast Cancer Symposium in 2024, INOVA 120 study came out, which was a novel phase 3 design, evaluating patients who had PIK3CA mutations in hormone receptor positive metastatic breast cancer. What was interesting about this study is they allowed patients who had progressed on prior adjuvant therapy or had completed their adjuvant therapy but were within 12 months of completing that adjuvant therapy and noted a recurrence. So presumably these are all high-risk patients. There's also other eligibility criteria, which included a fasting glucose of about hemoglobin A1C of less than 6, and some of us are practicing in the South and in America, and that may be rare, and so that kind of gave a lot of investigators pause. Do we not prescribe this medication because the blood sugar restrictions were so tight? And we'll talk about that. And so over 300 patients were randomized in a 1-to-1 fashion, and you can see here the treatment hours of alpelisib plus palbo plus fulvestrant versus palbo versus fulvestrant in the standard arm. And those who had PIK3CA mutations, who received a triplet therapy, had a 15-month progression-free survival over a 7.3 months according to the standard of care. Additionally, safety data, pretty comparable to what we see with alpelisib: hyperglycemia, diarrhea, stomatitis, and rash. Again, manageable AEs, but adverse events nevertheless. And then the third PI3 kinase AKT inhibitor I want to discuss is the study with Capitello 291. Again, our phase 3 randomized study in patients who are pre- and postmenopausal who had hormone receptor positive breast cancers, and over 50% of the patients enrolled in this study had prior CDK4/6 inhibitor exposure. The hemoglobin A1C was limited to less than 8 in this study, so not quite as stringent. So this was a large study enrolling over 700 patients, and you could see capi plus his fulvestrant in one arm, and then fulvestrant plus placebo in the other. And what we can note here is that if the patients had a PI3 kinase mutation, the progression-free survival was improved from 7.3 months versus 3.1 in the fulvestrant alone. Additionally, the AEs were very similar to prior PI3 kinase inhibitors presented today. And just moving along to ADCs and in the treatment of hormone receptor positive breast cancer, we now know that, again, endocrine therapy and the multiple targeted therapies are going to be the preferred way to go in the treatment of our patients with hormone receptor positive breast cancer. We also want to take into consideration patients who may have a germline mutation or even considerations for somatic mutations in PARP inhibitors. We saw that from Nadine Tong's presentation from the TBCRC during ASCO of 2024. But additionally, for those patients who have endocrine-resistant therapy or visceral crisis, can we utilize these ADCs earlier in systemic therapies? So we know that about 60 to 65% of hormone receptor positive breast cancers will be characterized as HER2 low, and about 20 to 25% will be HER2 ultra low. And we know that HER2 ultra low is defined as faint, incomplete membranous staining in about less than 10% of the cells here. So you can see that characterization there. So Destiny Breast 04 evaluated not only hormone receptor positive breast cancers, but also triple negative breast cancers in a metastatic setting, which were HER2 low. We know the majority of those patients enrolled were hormone receptor positive, and patients were randomized in a 2-to-1 fashion to TDXD versus treatment of physician's choice, which was capecitabine or a single agent chemotherapy. We can see here at the primary endpoint of progression-free survival to the left on that Kaplan-Meier curve that the hormone receptor positive breast cancers had a delta of 4.7 months compared to in the treatment arm compared to the standard of care arm. Additionally, there was an overall survival benefit in TDXD versus treatment of physician's choice in the hormone receptor positive HER2 low arm. Most recently during San Antonio, we saw a presentation solely from Destiny Breast 06, a phase 3 randomized study in hormone receptor positive HER2 low and HER2 ultra low in patients who had at least one line of prior chemotherapy or had up to 2 lines of endocrine therapy in the metastatic setting, and again, TDXD versus treatment of physician's choice. We can see here that there was a benefit in progression-free survival, not only in the HER2 low arm, which was noted as 1+ or 2+, but also in those HER2 ultra low as well. Additionally, there were some overall survival endpoints with a trend of a improvement in overall survival. Again, this data is not mature yet, and we'll be excited to see if we can expand TDXD to more patients who may need it once they have progressed off of endocrine therapy. And then next I wanted to talk about sacituzumab govitecan, again, which most of us are now really comfortable with utilizing this not only in triple negative breast cancer, but also in our metastatic hormone receptor positive breast cancers. Patients were randomized to sacituzumab, which is given on days 1 and 8 of a 21-day cycle versus treatment of physician's choice here. And what we see here is that these patients were most likely very heavily pretreated. The median prior of systemic chemotherapies were 3. Additionally, the primary endpoint was progression-free survival, and you can see a benefit trend for sacituzumab over treatment of physician's choice. Additionally, there was a hazard ratio of 0.79, showing a trend of overall survival benefit as well. And then lastly, there was a new FDA indication for datopotamab. That is another TROP2 directed ADC, very similar to sacituzumab, but it has the DXD payload, such as just like trastuzumab deruxtecan, which is very interesting, kind of taking the best of both worlds there from the ADCs. And these patients were had prior lines of chemotherapy as well. So in Dato-DXD, this is administered 6 milligrams per kg every 3 weeks versus treatment of physician's choice until progression of disease. And you can see here in this Kaplan-Meier curve that the progression-free survival in the ADC arm was 6.9 months versus 4.9 months. Adverse events were fairly similar to what we see in the ADCs, some stomatitis, some nausea, some evidence of interstitial lung disease, but we did notice a new AE of a dry eye and keratitis, which was about 22% of patients. So again, here are key take-home points here. CDK4/6 inhibitors remain the mainstay for endocrine-sensitive, hormone receptor-positive, HER2-negative breast cancer. The role of CDK4/6 inhibitor post CDK4/6 inhibitor may be beneficial in patients who have bone and soft tissue metastasis and may have had a prolonged response to CDK4/6 inhibitors for greater than 12 months. We certainly are still utilizing targeted therapy and the second-line therapy as a main focus of for treatment of metastatic hormone receptor-positive breast cancer, and liquid biopsies are becoming more prevalent. They're looking for those ESR1 mutations, PIK3CA mutations, AKT and PTEN alterations, and certainly testing your patients for germline BRCA1 or 2 will also be advised. And then lastly, for those patients who have visceral crisis or certainly become endocrine resistance, which we know many of our patients will become, checking those tumors for HER2 status, IHC of 1+ or 2+, thinking about TDXD in those settings. And then for the HER2 low patients, we have many options for datopotamab as well as sacituzumab. Thank you.
Thank you, Erica. I want to invite